things along those lines. So I just wanted to give a little bit of background about how I chose medicine and how I applied to medical school and what that process was like, and then also why I chose my field. So I went to Loyola University for undergrad, and I majored in journalism and Islamic world studies. During my undergraduate years, I completed my prerequisites in my first and second year, and then I took my MCAT in the summer after my second year. And then in my third year, for the second half of my third year, I studied abroad in Tunisia for 6 months. And then I came back and completed my fourth year of undergrad and, applied to medical school and did my interviews and all of that kind of stuff. And ultimately got accepted to a couple different MD programs in Chicago, Boston, Portland. And I ended up choosing to go to Loyola University of Chicago for medical school. And what I would say I took from that experience of applying to medical school really is that I felt like in undergrad there was a lot of pressure to be bio pre-med and have your application be only medical things, and to kind of go tit for tat with all the other pre-meds in terms of science research and bench lab research and all of this kind of stress and pressure to put on being the perfect med school applicant. And what I would say is that from interviewing, I really found that people were so drawn to the things that I did that were kind of outside of the box, whether it was having a journalism degree or studying abroad, or the volunteer work that I did that had nothing to do with medicine. I volunteered at a soup kitchen, and I spent a lot of time there in terms of working with farmers to get fresh foods to the soup kitchen and making fresh fruits and vegetables available to the homeless community, and really working to minimize waste in the city of Chicago from farmers markets in order to really funnel what would have otherwise been thrown out from a lot of local restaurants and grocery stores and things into the homeless community who really needed it. And I worked a lot on that project. And I also, I volunteered at a children's hospital, and I did have good amount of medical volunteering hours, certainly to prove that I've had exposure to the field and that I know what I'm getting myself into and that I like it. But I would always argue that being a genuine person and doing the things that you really like and the passions that you have that once you go into medical school you're not going to have as much time for, I think it's really important to really show that you're a well-rounded person and that you have passions outside of medicine and that you follow your heart into doing the things that you really like doing. And truthfully, if you love bench lab research and you love biochemistry, by all means, go for it. It'll shine through your words when you're talking about it, but that's definitely not me. So after starting medical school, I would say that my first 6 months were my hardest, because I did have a major in something outside of science, and I hadn't really done my science prereqs at this point in 2 years. And when medical school started, the first class was molecular cell biology and genetics, and it was kind of supposed to be a review course for everybody to kind of get on the same page before getting into anatomy and physiology. And it was this really truncated, fast course because they had assumed that everybody had done this all in college, and I really hadn't. So that class was really challenging for me. I felt like I was kind of, the rug was pulled out from under me, but then after that, it was everybody was on a total even playing field, and I did well in medical school. I got good grades. I did well on my steps, and by third year of medical school, I had talked to my faculty about letting me apply for a Fulbright scholarship. I had always dreamt of being a Fulbright and getting to pursue this opportunity to really go through the State Department, to be in a different country and do work and volunteerism with refugee populations and learn more about global health and public health in international settings. So I did a Fulbright scholarship between my third and my fourth year of medical school, and I went to Jordan for a year, and I worked with the United Nations Relief Works Agency to help build and what's the word that I'm looking for, to scale a diabetes education program that was existing before I got there, and to collect some data on the use of the diabetes education program in terms of outcomes. So I worked with this other NGO that helped them run a randomized control trial on the benefit of this particular diabetes education program through Microclinic International, and I was their fellow for a year, and I helped run the RCT, and I helped lead the scale of this diabetes education program. And then I went back and I finished my fourth year and took my step 2 and applied for residency. I would say during medical school, I did not think I wanted to do OBGYN. I actually thought that was the last specialty that I would have applied to. I think I had like a stereotype in my mind of what I thought OB would be and who I thought the type of person would be who went into obstetrics and gynecology. And I didn't think it was me. But then I did my rotation in OBGYN, and I just felt like it came so naturally to me. I really related to the patients, and all of my patients, I saw people that felt like, my friends, my family, my sisters, my mom, my aunts, and relating to the patients came really, really easily. And I also really liked the pathology that we were working with. Like, it was all very acute and easy to kind of see the start and the end to the pathology. Like, you're pregnant and then you're not, or you have a fibroid uterus, then we take it out and then it's done. You have the torched ovary, we fix it. Like, it was a lot of kind of acute or urgent diagnosis and pathology, and I really, really enjoyed it. So I kind of realized about myself that I do enjoy like rounding and thinking and like those kind of like more intellectual rounds, but at the same time, like, I got very kind of antsy. Like, I wanted to do something with the information, and I tried to really like anesthesia. I tried to like neurology. I did extra rotations and those things, kind of trying to force myself to like anything but OBGYN, but I just kept coming back to it. I think the patient population really won me over, and the diversity of what we do really won me over in terms of dealing with abnormal pap smears and, treating precancerous conditions of the uterus, the cervix, the ovaries, dealing with all kinds of complex medical conditions that only become more complex when you add on a pregnancy to it. So I ended up doing a couple of extra rotations in OBGYN. I did maternal fetal medicine, and I also did GYN oncology and urogynecology. I saw really like pretty full spectrum of what OBGYNs can do and can practice. And I ended up applying for OBGYN, and I matched at University of Chicago in a 4-year residency program for obstetrics and gynecology. All of our ACGME accredited residencies are 4 years. And throughout those 4 years, you do probably like a pretty even mix of obstetrics and gynecology. You spend a lot of time on the labor ward, both doing day shifts and night shifts, and getting to see a lot of really acute and urgent medical needs for the obstetrics population. It's obviously a ton of vaginal deliveries and cesarean sections, but there's, a lot of medicine that really goes into caring for a patient throughout pregnancy and on labor and delivery. like, imagine a patient who has Addison's disease, which means adrenal insufficiency, and they have to take long-term steroids to support all the processes in their body that need corticosteroids and mineralocorticoids to function. Well, during pregnancy, during delivery, you need stress dosing for those steroids, since labor is an additional stress on the body. We have patients who have high blood pressure, have diabetes, who are on crazy doses of insulin, and you have to manage their sugars during labor and delivery. I mean, these are things that we do on an average, during an average shift, let alone complications that arise from pregnancy, like preeclampsia or acute fatty liver. So it's a lot of opportunity to kind of mix medicine and surgery, while focusing on a very particular time in a patient's life. So I was really drawn to all of that. And in residency, I kind of identified that I felt like I wanted to round out my training a little bit more with more time learning about pediatric and adolescent gynecology. We had some exposure to it in residency, but not a ton. And I felt like in the outpatient setting, there were so many times that a mom would be like, hey, can you see my daughter? She's having X, Y, and Z going on. And I felt like we didn't really have like enough training in knowing how to approach those things differently than approaching adult pathology. So I did a fellowship in pediatric and adolescent gynecology, focusing on congenital anomalies of the reproductive tract, as well as medical comorbidities that can affect pubertal development or can affect the menstrual cycle when it starts. So I did a 1-year fellowship in Toronto at Sick Kids Hospital, which you guys are very close to, being in Detroit. And now I'm back, and this is my first year practicing medicine independently outside of fellowship, and it's been a wild ride. It's residency definitely prepares you for this in a lot of ways, but you really do have to be a lifelong learner. Like, I still come home and I'm like reading my textbooks and looking things up, and it's like you'll never know enough to really start, and at some point you just have to start. But it's definitely not a field for someone who kind of wants to pack it all in and just go to work and come home at 5 and be done. The work really never finishes in terms of what you have to learn and what you have to prepare for. And the task saturation while you're at work is really high. Like, you're always worried about 15 different patients at the same time. And you really have to be able to manage a lot of multitasking while you're at work. And that's every day while you're in clinic or you're in the hospital. It's a lot of multitasking. So those are definitely things that you have to want to be an OBGYN, is you have to like the hustle and bustle. I always joke that it's like made for a person who grew up in a city and is kind of rough around the edges, because it's like you have to kind of like a lot of different noises going off at the same time, and a lot of different things happening all at once, and just kind of be a person who's ready for anything. I personally like that. I'm a little bit of an adrenaline junkie, and I really like kind of pushing myself to my limit in terms of my comfort zone. I love getting out of my comfort zone. So I guess I'll just conclude with that, and I'll take some questions for 10 minutes while I'm making my way in my house and setting up my computer, and then we can do our case study.
Thank you so much for sharing all of that. So if you had to start your entire journey to medicine over, would you do anything differently?
Ooh, that's a good question. I don't think so. I really don't think so. I think I have moments where I'm like, wish that I did another fellowship in minimally invasive gynecologic surgery, and just got more comfortable in the operating room before being independent. But I feel like it's because you guys are talking to me in my first year of practice. So I'm just like, sometimes overwhelmed by having left the warm blanket of training. But I would say in general, no, I'm happy with how things turned out. And I don't think there's anything that I would have changed.
Okay, so there's a few questions in the chat. Somebody said, being that your major was outside the norm, do you think it's given you any advantages in medical school or your professional career?
Yes, I do. One is that I find that I relate to people quite easily, and I really feel in terms of communication skills, like with patients and with their families and with my coworkers, that I in general just feel like those types of conversations and dynamics come pretty easily to me. And I don't think that would be the case if I had only been really employing and utilizing medical language for the past 8 years. I think it's kind of helpful that I had to step outside of that and be around non-medical people for a lot of my classes, and get some background in journalism. I mean, journalism is all about using written and spoken language to either document something that's happening or advocate on behalf of a population, share their story, kind of uncover something that needs to be uncovered. And I actually think that that's a lot like medicine in a lot of ways. We have to use spoken and written language to document people's histories. And we ultimately have to use the information that we're gathering to either advocate for somebody, make certain decisions for them, help them figure out what their next step is. And I think that, it's not conventional journalism, but I do find that I'm using some of those skills on a day-to-day basis.
Someone said, I've heard that there is a gender bias in offering healthcare, specifically that women's health needs aren't taken as seriously as men's. Given your field, what is your perspective on this?
So that's a very good question. I would say that there's always some truth to that. And you can look at any medical facility. Their newest wards are always going to be like cardiac, ortho, like their newest ORs, newest technologies, like biggest, freshest instruments, most money into research. It's always into like cardiac and ortho. And it's like very rarely into labor and delivery or the gynecology suites in the OR. Like, it's kind of sensical in some ways because a lot of the money in hospitals is made in some of those other areas. But at the same time, like, women are 50% of the population, and it would make sense to like have just as high of a quality of technology and resources and infrastructure for women's health. But I think it's kind of, I don't know. I mean, there is definitely truth to it, but at the same time, it's not anything that's like that noticeable in your day-to-day life. Aside from the OR that I operate in, being the oldest one probably in the hospital. But my hospital is all like pretty new in general. Our infrastructure is a lot nicer than what it was in Canada, so I certainly can't complain.
So somebody asked, can you talk about the differences between being an OB-GYN versus a women's health nurse practitioner?
I will say that nurse practitioners are just going to have a more limited scope for a lot of reasons, right? Like, they're not going to be doing surgeries, and they're not going to be delivering babies, and certainly not doing any kind of complex women's health care. So they'll do like outpatient care. You'll see nurse practitioner. We work with a nurse practitioner who's lovely, and she helps us see prenatal patients for visits. And I have a lot of respect for her and really enjoy having her on the team. But I would say that it's not the same scope of practice and it's not the same training. So the amount of reading and like background that I have in anatomy and physiology, biochemistry, pharmacology, by nature, someone who goes through nurse practitioner training is not necessarily going to have all of that. So it kind of limits the depth of their understanding of the field as well. But it doesn't mean that there isn't a role for them. Like, we definitely need help seeing low risk prenatal patients. So, there's definitely a possibility for them to be involved with our patient population. It's just not in the same scope.
Someone said, can you talk a little bit about your study abroad for 6 months in Tunisia? Was it medical based?
It had nothing to do with medicine. It was for my journalism major. I went there, and it was like a specific program through the School of International Training, SIT, and it was specifically geared towards people who were interested in media. And we studied the role of media in Tunisia. At that time, it was pre-Arab Spring, so there was a lot of kind of like interesting dynamics between like the police state that is Tunisia and how regulated and censored their media was, and the political dynamics that were in the country at the time. And it was really interesting because you could really feel like something was brewing there, but hadn't quite bubbled up to the surface yet. And then the Arab Spring happened like the following year, or a couple of years later, I guess. So it was very, very, very interesting, but it was not medical. And I would say that genuinely, I encourage everybody to pursue their passions and dreams outside of medicine, because if you do go into medical school, you will spend the rest of your life reading a textbook, which is what I'm going to do after I get off the phone with you guys.
So somebody said, can you talk about the Fulbright scholarship a little bit more? What are the qualifications?
Yeah, so Fulbright is this really, really fantastic scholarship through the State Department. And essentially it was started, I think, in the era of JFK, where he wanted there to be more citizen ambassadors for the United States going out into the world and representing Americans in a positive light, and integrating into communities and meeting people and doing positive kind of like volunteerism or work, or making efforts to really get to know people in a way and have some kind of a altruistic aspect to what they did while they were there. And I learned about this program when I was in high school because I want to say it was like my high school social studies teacher. He was a Fulbright scholar and he talked about the program, and I was obsessed. And I was like, I'm going to be a Fulbright. And it was always like a goal and a dream that I had. So I applied when I was actually in college, and then I decided not to take a year off in college. I kind of just wanted to like get into med school and start med school and stuff, but it never stopped being a dream of mine. And I think it was a part and a parcel of the fact that I did well in medical school and I had good grades and I got a good score on my steps. So I think my school was really pretty reassured that I could go away for a year and come back and still do well. And the opportunity is a pretty prestigious one and it's pretty competitive to get it. So they were like, well, if you get it, like, we're not going to stand in your way and prevent you from going. So the application process is pretty lengthy. I honestly don't remember it that well. It was a while ago and a lot has happened since, but I do remember that it was like an essay that I had to write and an application I had to fill out. And then I also had to go and interview with a bunch of people prior to getting accepted. And then you apply, it's a country-specific application, so you have to pick what country you're applying to. And then you either get accepted or rejected. And that's pretty much as much as that. That's pretty much the most that I can remember about the application process. Any other questions?
Someone said, what is your favorite or most valuable thing that you do or see on a regular basis?
Ooh, great question. God, there's a lot. There's definitely a lot. I would say, obviously, like, delivering babies is very rewarding. Labor and delivery is like my happy place. It's so busy and so high energy and high stakes, and you can't blink, like, or you'll miss something. And I kind of love that feeling for like a shift, you know, where you're there for 12 or 24 hours and you're just like running around like a crazy person. And obviously, like, having a baby, going through labor and having a delivery, it's one of the most dangerous things, if not the most dangerous thing, an American woman will do in her lifetime. So keeping women and their babies safe through that experience is really what drives me. And I did train in higher risk obstetrics. So, you know, I do everything from very premature deliveries to cesarean sections at all gestational ages, dealing with high blood pressures, high blood sugars, multiple gestations, meaning twin or triplet deliveries, like all kinds of things. And for me, that's very rewarding. Like, when someone is scared and kind of high risk and they are, you know, really looking to entrust their care to somebody to have to worry about things so they don't have to, that really is like the highlight and privilege of my life. So I feel very thankful that I get to do that as my job. It totally exhausts me and mentally like puts my brain and my heart through the ringer, but I really truly enjoy it. And I feel like it's one of those things where you have to like push yourself and scare yourself sometimes and do things that totally terrify you all the time. And I get a high off of that, but not everybody does.
Somebody said, how do you recommend framing having a non-science field on your application and interviews? She said that she's really worried that adcoms won't take her interest in medicine seriously.
So I actually just pulled up my computer. Let me exit out of here. Okay. I'm going to get off my phone.
I think you're on mute.
Dr. Elborno, you're on mute.
Sorry, I fixed it. Okay, so I would say that about 50% of medical students in today's day and age are non-traditional medical students, meaning they had a life outside of medicine before they applied to medical school. And so it's not uncommon at all that they see a range of backgrounds of people who are applying to medical school. And I think the second thing, it's all about wordsmithing and all about how you present yourself and how you explain your major. So let's say you're like a history major or you're a sociology major, something like that. And you did your pre-med prereqs, you did the MCAT, you did go down those things, you have a good science GPA, you did something medical, like you have to do something, like you have to have a good amount of shadowing hours or volunteer hours in a hospital, like something to really talk about and prove that, like, I've been exposed to this, I know what I'm getting myself into, and I'm going to be good at it. Like, those are the three things that have to be true when you're applying to medical school, that you can say, I have exposure to this, I know what I'm getting myself into, and I'm going to be good at it because of X, Y, and Z. Now, the third point is really where you can bring in your non-traditional major. You can say, I know I'm going to be good at it because, and like for myself, I would say, in journalism, I really learned, one, how to communicate with and talk to people in sensitive periods of times in their life. I learned how to advocate on behalf of people who maybe don't usually have agency in their lives. And I also really learned that as much as I like documenting what's happening, I also feel like my hands are a little bit tied, and I always wanted to do more. I always, imagined ways that I could help people beyond just writing about their stories. And, that ultimately took me down a path of exploring medical school and, X, Y, and Z. So it's a lot about wordsmithing of like, how can you weave your non-traditional major into proving to this medical school that you know what you're getting into, you've had exposure to it, and that you're going to be good at it. And, ultimately that third point, it's impossible to prove if you don't do well on your pre-med prereqs and have a good MCAT. Does it have to be stellar? No, I don't think my MCAT was stellar. I think I got like a 30. I don't even know if the scoring is the same, but it wasn't like, blow it out of the water. It was like a good score, but it was pretty average. And I think, between that and like a pretty strong science GPA and, a good application and really showing that you know what you're getting into and you've had good exposure to it, it's kind of hard, to not be a strong applicant. I think where people will falter is if one of those three things is not true. And I don't think that your major being outside of biology or chemistry or something like that makes one of those three things not true. In fact, I think it actually proves a stronger point of I know what I'm getting into, and I've explored things outside of medicine, and I keep coming back to this. Like, I'm not like tunnel vision. I've only been exposed to one thing and I don't know anything outside of it. It makes them really believe that you're a well-rounded person. And at the end of the day, they want to be accepting people with like humanity and maturity and world experience and the ability to like get knocked down and get back up again and have a thick skin and all of that kind of stuff, which is all really important. And you really get all of that from, life experience beyond just following like a very dictated path, like really showing that you chose your own path and that you believe in it. I think it's so important.
Thank you so much for answering those questions. I know that there's like two more, but just for time's sake, I think we can just start the case study and then if we have some time at the end.
Okay, let me find the case study. Oh, you guys are gonna have to put up with me today. Let me see which one I want to do. I have a bunch that are ready, but we'll do this one. It's a pretty short one. It said host disabled, attendee screen sharing. You have to make me the co-host now that I switched from my computer or my phone to my computer.
Okay, let me do that. Okay, it should work now.
Okay, great. So as you guys remember, I have a fellowship in pediatric and adolescent gynecology. So I thought I would present kind of a unique reproductive endocrinology case from a pediatric patient. So this patient is a 14-month-old girl who presents with a 3-day history of vaginal bleeding. On examination, she has Tanner 2 breast and an estrogenized hymen, and ultrasound demonstrates a 2-centimeter simple right ovarian cyst. What is the most likely diagnosis? So I'm just going to go back a little bit and talk about what some of these terms mean. So puberty is the sequence of events that take place in the transformation of a child into a young adult. And it really encompasses the development of secondary sexual characteristics and the acquisition of a reproductive capability. It relies on the hypothalamic pituitary axis getting turned on and starting to communicate with the gonads, which in the case of assigned female at birth or a XX chromosome, in the case of a patient with XX chromosomes, that means that your hypothalamic pituitary axis is going to be communicating with your ovaries, and your ovaries are going to start secreting estrogen, which is the hormone that's responsible for the development of secondary sexual characteristics in a female. Now, the way that the hypothalamus gets turned on is something that we don't fully understand. It's probably related to some molecules like kisspeptin, leptin, and other like nature/nurture clues that the brain gets a sense that it should turn on, but we still really don't fully understand why the body turns on this pubertal arch when it does. But ultimately what happens is there's pulsatile GnRH that is released from the hypothalamus, and that causes the anterior pituitary to release FSH and LH. And FSH is going to help stimulate follicles to grow in the ovarian cortex. And during the process of follicular stimulation, one of those follicles will become a dominant follicle in each cycle. And when the estrogen level reaches a certain threshold, once that dominant follicle becomes really active and makes a ton of estrogen, the estrogen level is going to reach a certain threshold, at which point it's going to have a positive feedback on LH, and LH is going to spike, which is going to be a stimulus cause to secrete the egg from the follicle. And then the shell of the egg or the shell of the follicle is going to stay behind and make progesterone from what is now called the corpus luteum. And that's what you see here. I don't know if you guys can see my cursor. In the early years prior to puberty, the HPO axis is suppressed. The suppression is due to two mechanisms. Probably maximal sensitivity of the negative feedback effect of low circulating levels of estradiol in prepubertal children, and CNS inhibition of GnRH secretion. And just as we were talking about, by approximately age 11, there's a gradual loss of sensitivity to the negative feedback of sex steroids, plus a loss of intrinsic CNS inhibition of hypothalamic GnRH release. And then that ultimately allows the pulsatile secretion of GnRH to lead to FSH and LH secretion. FSH and LH is secreted in a similar pattern that mirrors the pattern of GnRH pulses, and that's what ultimately promotes ovarian follicle maturation and sex steroid production. By middle to late puberty, that's the point at which your the axis is going to develop the ability for positive feedback mechanism on LH, and is going to allow for complete and ovulatory cycles. Prior to this, the cycles are anovulatory, meaning an egg is not released, and it's mostly estrogen that is being secreted from the ovaries. Trying to... The onset of puberty is determined by primarily genetic factors, but certain other things like nutritional status and environmental factors, psychological factors can also influence the age at which puberty is initiated. Right now in the US, the mean age of periods starting is 12 and a half, while in Haiti, the mean age of periods starting is around 15 and a half. And that's likely both due to changes in genetics and nutritional status, psychological factors, geographic location, etc. Puberty proceeds through 5 stages from childhood to maturity, and the first physical sign of puberty is usually breast budding. That's called thelarchy. which is followed by the appearance of pubic hair and axillary hair, also known as pubarchy or adrenarchy, followed by the maximal growth or peak height velocity, also known as the growth spurt, and then ending with menarche, which is the onset of menstrual cycles. We describe stages of puberty clinically as Tanner stages, where you start at 1, meaning no breast tissue and no pubic hair. And then Tanner 2 is there's breast buds just behind the areola and the start of fine downy hair growing, both in the axillary region and pubic hair. And then Tanner 3 is where the breast tissue extends beyond the areola and pubic hair is starting to have more of an adult type texture. Tanner 4 is where there's a secondary mound of breast tissue that grows behind the areola. So then you have now what looks like a bulb of breast tissue, and then on top of it, another smaller bulb of breast tissue. That's known as the secondary mound. And Tanner 4 for pubic hair is where the pubic hair actually reaches to the inguinal crease, but doesn't extend beyond it onto the inner thighs. Tanner 5 is adult contour of the breast tissue, and pubic hair is actually extending beyond to the inner thighs. So breast development usually starts anywhere from age 8 to 13. 8 is considered a normal age for it to start, and 13 is like the latest that it should start. Beyond 13, it's considered delayed puberty. Earlier than 6 to 8, depending on the textbook that you read, is considered precocious puberty. And again, we talked about breast development happening first, then pubic hair, then your peak height velocity is reached, and then menarche starts. We do consider the menstrual cycle a vital sign, and we do consider the pubertal arch a vital sign. So if a patient's puberty is not following in the correct order, either is happening too soon, too late, too quick, or too slow, or if the periods are starting and they're like irregular, heavy, long, infrequent, all of those things could potentially be signs of underlying pathophysiology that needs to be addressed. So the definition of precocious puberty in girls is the development of any secondary sexual characteristics before the age of 8. It's definitely more concerning if it's before the age of 6. That's usually more likely to be pathologic. Between the ages of 6 to 8, there's kind of like a recognition that it could be pathology, but very unlikely to be. And we do a lot of like monitoring and expectant management when we're evaluating precocity between 6 to 8. We're going to skip all of this. These are all things that would spark an investigation of precocious puberty. So any signs of secondary sexual characteristics before the age of 6, progression to Tanner 3, breast development before the age of 8, both pubic hair and breast development younger than 8, short stature with puberty younger than 8, bone advancement more than 2 years. So whenever we have a concern for precocity, we always get a bone age. Oh my gosh, I just got mayonnaise in my hair. Ignore me. Anytime we have a concern for precocity, we get something called a bone age, which compares the chronologic age of the patient to what their bones actually look like on X-ray. And if the patient's bone age is more than 2 years advanced from their chronologic age, that's definitely something that needs more investigation. And if there's any rapid progression of puberty younger than 8, meaning they're speeding through Tanner stages in less than 6 months, and any contrasexual precocious puberty, meaning an XX patient who's developing male type pubertal characteristics or male type secondary sexual characteristics, those are all things that warrant investigation. Precocious puberty can be divided into central or peripheral. Central is also known as true precocity, which means that there's an early turning on of that HPO axis. And central precocious puberty is always isosexual, meaning gender appropriate, while peripheral precocious puberty is autonomous of the HPO axis and it can either be gender appropriate isosexual or inappropriate contrasexual. With central precocity, the onset is early, but the pattern and the timing of pubertal events is a normal sequence, and it can occur in the association with a variety of CNS lesions, but 80 to 90% of children will have no identifiable cause. While peripheral precocious puberty can happen from the secretion of sex hormones, either from the gonads or from the adrenal glands, in relation to either ovarian cysts or tumors, exogenous estrogen, meaning that the patient's actually like taking like a birth control pill, some kind of adrenal pathology like congenital adrenal hyperplasia, pituitary gonadotropin secreting tumors like an FSH secreting tumor, or if you have a pituitary tumor that is secreting something else, can still affect the HPO axis and kind of turn on spuriously the secretion of FSH or LH. Primary hypothyroidism that's extreme can also turn on the production of FSH and LH, and McCune-Albright syndrome, which we'll talk about in a second. Precocious development of secondary sexual characteristics in girls, like we talked about, can be peripheral precocity, which is always concerning and needs to be evaluated, progressive central precocious puberty, which is related to CNS tumors, malformations, or idiopathic, but it's happening in a very quick timeline. And that's usually something that we treat or monitor very closely. And then we have benign or non-progressive pubertal variants, meaning somebody can start like some breast development or some pubic hair development at between 6 to 8, but then it kind of like starts and stops and starts and stops. And it's associated with some kind of mini activations of the HPO axis, but it's not full activations of the HPO axis. And again, remember with peripheral precocious puberty, there's a really rapid onset of symptoms and a very fast progression, while with central, it has a more normal tempo. Any types of CNS symptoms or pertinent medical history like birth trauma, encephalitis, seizures, headaches, or visual changes are really important to get from the history, as well as any abdominal pain, urinary or bowel symptoms. And then certainly asking for a family history of anything that is more genetic, like congenital adrenal hyperplasia, which is autosomal recessive. Trait, any familial history of early puberty or short stature, neurofibromatosis, or anything along those lines. On physical exam, we get a height, a weight, a neuro exam. We do a skin exam looking for acne, axillary hair, cafe au lait spots. We check the thyroid for any type of goiter. And then we'll definitely do Tanner staging of the breasts and external genitalia. The workup typically includes, in addition to history and a physical exam, FSH and LH, estradiol. We would check for androgens if there's any sign of contrasexual precocious puberty, and a TSH, plus an ultrasound of the pelvis to look for autonomous ovarian cysts, plus a bone age to compare to the chronologic age, plus or minus an MRI of the CNS if there's any concern that this is a central precocious process. If it's starting less than 6, we almost always get a MRI of the brain. If it's between 6 to 8, it's kind of like, you know, more edgy in terms of whether or not you'd get it, and it would really depend on the tempo. And occasionally a GNRH stim test if the FSH or LH is more equivocal and we can't really interpret if it's prepubertal or postpubertal. So this is kind of a typical algorithm for evaluating precocious puberty in girls less than 8. We would start by sending the FSH, LH, estradiol, TSH plus a bone age. And if the basal LH is less than 0.2, that would have you doing more of an evaluation for peripheral precocious puberty, because remember the LH is part of the HPO axis, and if it's low and there's no sign that the HPO axis is turned on, then we need to do a more clinical evaluation for peripheral precocious puberty. And if we find no peripheral etiology of the precocity, and there's no progression over the next 3 to 6 months while we observe, then you'll just continue observing. There's really nothing to do about it. But if there is progression, then you can consider a GNRH stim test and potentially consider referral to a pediatric endocrinologist. If the initial LH is greater than 0.3, which means post-pubertal, then we can certainly expect that there's going to be progression in the pubertal status over the next 6 months. You don't need to do a GNRH stim test because obviously the LH is already elevated and consistent with the HPO axis being turned on. And then depending on some other clinical variables, you may decide to get an MRI depending on how the tempo has been and how old the patient is. And then certainly depending on what the bone age is and the predicted adult height of the patient is compared to the mid-parental height, we could decide to treat the patient with a medication called a GnRH agonist. So ultimately, if we think that their puberty starting early is going to make it so that their growth plates close prematurely before they're really able to reach their peak height velocity, because remember that the tempo of things is pretty off and could be happening more quickly than what the bones are would ultimately need for the patient to reach the peak height velocity and final adult height, then you can treat with a medication to essentially turn off the HPO axis to give the bones more time to be in a growth phase before reaching a point at which the growth plates close. So this is a question that we always ask in terms of what's the single most useful test for the evaluation of precocious puberty, and that answer is always a bone age, because it gives us really a sense of how much hormone is around and has it been around in high enough doses and for long enough to affect the bone age. And if the bone age is not affected, then it's probably more so a non-progressive clinical variant, and if it's not affecting the bone age, then we don't care as much, because then it's not going to be something clinically that needs to be treated and would affect final adult height. So let's go back to our case. Now that you guys have some of the terminology in the background, it's a 14-month-old girl who presents with 3 days of vaginal bleeding. On exam, she has Tanner 2 breasts, so that means that there's a breast bud there under the areola. And she also has an estrogenized hymen. And the hymen essentially is a physical exam finding that we look at to assess estrogenization on the pelvic exam, because a hymen in a pre-pubertal patient is very thin and red and more taut. But when it's been exposed to estrogen, the hymen becomes kind of fluffy and pink and more flexible, and it can kind of give us a sense of estrogen status as well. In this moment, I'll just give a quick plug that the hymen is not a physical exam finding that can tell you anything about the sexual activity of a patient beyond puberty. So pre-pubertally, certainly if there's been a case of sexual abuse, there are certain exam features that we can see on the hymen that might be suggestive of potential sexual abuse or forced insertion of something into the vagina. But beyond puberty, the hymen, as I said, it's fluffy and it's pink and it's flexible, and it does not have some magical finding on an exam that is consistent with sexual activity. And there's no medical basis for something like a virginity test, where people come in being, requesting some kind of a letter to say oh, can you say that you examined me and prove that I'm a virgin? There's no medical basis to that. That's not a real thing. And I have had patients come in and ask me for things like that. And I spend a long time in rooms with patients explaining to them that that's not a thing. The only way that I can know if my patients are sexually active is by asking. Beyond that, there's no physical exam finding to prove whether or not someone has been sexually active. I guess aside from them being pregnant, that's the only thing that I can say I can see on physical exam that would say you've definitely been sexually active. So for this patient, now that we've gone on a tangent, we'll go back to our patient. What's the most likely diagnosis? So for this patient, we suspect that she has autonomous functional ovarian cysts. About 2 to 5% of prepubertal girls have ovarian cysts, and about 5% of them will produce estrogen. They are the most common cause of peripheral precocious puberty in girls, and the typical presentation includes either transient breast development and or vaginal discharge and bleeding. An ovarian cyst may be seen on ultrasound, or it may not be seen if it's after resolution and the patient's now coming to you for evaluation a couple weeks later. The bone age will not be advanced, and the LH will remain low. So let's go back to our patient and say, what if on exam you found this, and in her past medical history, she has a history of a femur fracture? This would be considered consistent with McCune-Albright syndrome, which is a rare disorder with a classic triad of precocious puberty, café au lait macules, and polyostotic fibrous dysplasia. Patients with McCune-Albright syndrome have a somatic, meaning a postzygotic, mutation of the alpha subunit of the G3 protein, which activates adenyl cyclase, which leads to continued stimulation of endocrine function, and ultimately is a version of peripheral precocious puberty. So for McCune-Albright syndrome, we really struggle with these patients in terms of treating the peripheral precocious puberty, because you can't give the GnRH agonist, which suppresses the HPO axis, because this is not HPO axis dependent. The estradiol is coming from these autonomous ovarian cysts, and you can't remove these ovarian cysts every time they come up. There is some suggestion that you can give a medication called an aromatase inhibitor, which limits the production of estrogen, which is enzyme dependent on an enzyme called aromatase. But I mean, obviously, this is a very rare disorder. It doesn't come up very often. So that's more like an experimental thing. With central precocious puberty, the primary goal of treatment is preservation of height potential. We use GnRH agonists to downregulate the release of FSH and LH, to stop puberty progression, and to cause a cessation or a slowing of the growth acceleration. It's indicated when the bone age is more than 2 years advanced, or when a patient has a decrease in predicted adult height, or for those that are less than 6 years old for more like psychological or behavioral reasons, as it would, be psychosocially very complex for a patient who's like 6 to start getting a period. The goal is to stop treatment when the bone age is about 11 to 12, and at that point, then you can take them off the GnRH agonist. So with that, I'll stop. I know I kind of flew through those slides, but I just wanted to introduce you to some pubertal physiology, and then also walk you through some cases where the pubertal arch starts too early, and that can either be central or peripheral, and then talk you through how we evaluate it and how we treat it. And I will stop sharing my screen. And if are there any questions or anything about those slides? I know I literally sped through it. I think I ran out of breath.
If anybody has any questions, you guys are welcome to say it in the chat or just unmute yourselves.
So would there not necessarily be any way to know why that particular patient was experiencing those symptoms, and you would just focus on the treatment?
Well, we are looking for the cause. So I'll just go back to our workup is always to look for a cause. But with central precocious puberty, the grand majority of the time it's idiopathic. The HPO axis turns on early and we don't know why. So that's why our treatment is oriented at turning off the HPO axis. But when it's peripheral, not HPO axis dependent, then you have to treat the cause. So you either have to like remove the cyst or, you know, treat whatever is causing the peripheral, you know, like if the patient's taking birth control pills, she's asked to stop eating her mom's birth control pills, whatever. Like peripheral precocity always has a cause, but central doesn't always have a cause. It's usually idiopathic stimulation of the HPO axis, and then you just shut down the HPO axis until the patient's kind of at a more normal age to progress through puberty / at a bone age of about 11 to 12. Does that make sense?
Yes, absolutely. Thank you.
Any other questions?
All right, I think we can wrap up the session there. Thank you so much for the incredible and insightful session, Dr. Elborno. And thank you for doing this despite everything you had going on. I really enjoyed how educational this was, and I hope to have a session with you again in the future. If you would like to post your social media handles or links to any of your business endeavors or anything like that in the chat, please feel free to do so. To our Wayne State University students, please make sure you complete the Google survey posted in our Zoom chat summarizing this session to obtain your shadow hours. Thank you all, and I hope you have a great night. And please hang around for at least 5 minutes to make sure that the survey is working for you.